For decades, surgery of the nose and paranasal sinuses has been the gold standard for the treatment of patients with chronic rhinosinusitis with nasal polyps that are uncontrolled by medical therapy. But surgery isn't a panacea. In severe patients, symptoms may return and the disease becomes uncontrolled, even with appropriate medical therapy. Further surgery follows with mixed results. But have we now reached a stage where new drugs can offer a paradigm shift in the treatment of CRS with NP, where surgery is no longer considered the gold standard? No surgery or no surgery? That is the question. This is the EUFOREA Innovation Forum debate on CRS with NP, setting the new gold standard. Hello, I'm Dr. David Bull and welcome to this EUFOREA Innovation Forum debate. It's fantastic to have your company. Chronic rhinosinusitis with nasal polyps, or CRS with NP, is a chronic inflammatory condition of the nose and the paranasal sinuses, which causes a significant impact on the lives of those patients affected. Now, it's estimated to affect about 1 to 4% of the general population and about 25 to 30% of patients with chronic rhinosinusitis. And there is an underlying inflammatory process at work which is called type 2 inflammation. And this means that CRS with NP often presents with comorbidities, including asthma and allergies. Patients suffering from CRS with NP experience symptoms of nasal obstruction, smell dysfunction with anosmia, continuous nasal discharge and facial pain, and all of these have a massive impact on the patient's quality of life. And living with this condition can also profoundly affect people's mental health, and psychological symptoms, including depression, are common. And with so many people affected by the disease, there is also a significant economic impact too, including the cost of providing recurrent healthcare, absenteeism from work and lost work productivity. So it is vital that we continually improve the care that we can offer to patients with CRS with NP and in turn improve their quality of life. Well, to bring the subject alive and to debate what the new gold standard for CRS with NP should be, we've assembled a world-leading panel of experts and an advocate from all parts of the globe. And I'm delighted to introduce them all to you now. From Amsterdam in the Netherlands, Professor Witske Fokkens. She is Professor of Otorhinolaryngology at the Academic Medical Centre. She is also Secretary General of the European Rhinological Society and Chair of the European Position Paper on Rhinosinusitis and Nasal Polyps, or EPOS. From Rome in Italy, Dr. Eugenio De Corso. He is an ENT specialist in the Institute of Otorhinolaryngology at the Gemelli University Hospital Foundation and leading the Italian Registry on Biologics for CRS with NP. From Norfolk, Virginia in the United States, Professor Joe Hahn. He is Chief of the Division of Rhinology and Endoscopic Sinus and Skull-Base Surgery at Eastern Virginia Medical School. From Barcelona in Spain, Professor Joaquim Mullol, who is Director of the Rhinology Unit and Smell Clinic in the ENT Department of the Hospital Clinic IDIBABS. And last but by no means least, from Haarlem in the Netherlands, Alexandra Banning, representing the EUFOREA Patient Advisory Board. Now, we're going to divide our debate into three sections, and the first section will be about nasal polyps in general. We'll talk about the disease characteristics, what CRS with NP is, the historical treatments for the condition, and the mechanism underlying it, that is, type 2 inflammation. The second section will address the advent of biologics in the treatment arsenal, and we'll talk about their advantages, their role in the treatment of patients, and how they can improve patients' lives. And the third section will look at the challenges to implementing new therapies and the ambitions and aspirations for patient care. So let's start our debate looking at nasal polyps and the role of sinus surgery. Now, nasal polyps is a form of chronic rhinosinusitis with benign inflammatory structures that arise from the mucosa of the paranasal sinuses. Chronic sinusitis can exist with or without nasal polyps, but it's still unclear why some patients develop nasal polyps and others do not. First-line treatment tends to be the use of medication to reduce inflammation, and surgery is recommended as the second-line treatment. But don't take my word for it. Let us now talk to the experts themselves. I'd like to start, if I may, with you, Professor Joe Han. Let's start right at the very beginning, if we may. Could you just tell us what nasal polyps are, how many people have them, and how many of them then have CRS with NP?
So I would say, chronic sinusitis is actually a very common chronic disease. In the U.S., it varies between 11 to 17% of the U.S. population. And the reason why it's not completely accurate in the U.S. is because the database in diagnosing CRS is not very well collected. But we do know that that CRS with nasal polyp, meaning that based on physical exam or on nasal endoscopy, that you can see a polyp coming out of the osteomeal complex. We know that if you could see it, these patients who have chronic sinusitis would then be determined as chronic sinusitis with nasal polyp. Now, as you mentioned earlier, it does account for 25 to 33% of the patients with chronic sinusitis. But, there are new studies that are coming out that when we're looking at the type of inflammation in patients with CRS, we may have it wrong. Maybe the percentage of patients with CRS with nasal polyp may be higher. So, for example, when you're doing sinus surgery, sometimes you don't see polyps in the osteomeal complex, but when we're opening up into the sinus cavity, we see your typical polyps. So then would that patient be a CRS with nasal polyp? So the definition of CRS with nasal polyp may be further refined.
Thank you very much indeed. May I move to you now, Professor Fockins? I talked a bit there about type 2 inflammation. Could you explain exactly what type 2 inflammation is?
Certainly. Well, I'll try. Type 2 inflammation is a form of inflammation that is around eosinophils, a certain inflammatory cell that you can find in the polyps, in the nose, but also, for example, in the lungs when patients have asthma. These eosinophils can be very aggressive cells, and they are pulled into the tissue and activated in the tissue by a number of cytokines. And important cytokines are IL-5 and IL-4 and IL-13. And these cytokines make that cells can talk to each other, and in that way make the inflammation in the polyp.
Thank you very much indeed. That was a fantastic explanation of type 2 inflammation. And perhaps I may now bring in Professor De Corso. I said really right at the beginning that the gold standard was always considered to be sinus surgery in the treatment of uncontrolled CRSwNP, i.e. those people who don't respond to medical therapy after surgery. And so for me, it does seem to make perfect sense that you remove the obstruction. But I don't think it's that simple, is it?
It's not so simply. I believe that the role of surgery should be reconsidered in the light of the new therapeutic opportunity. And the most important question is now we are doing first-time surgery on revision surgery. Surgery is very effective in this patient. Usually it leads to a very quick relief of symptoms, and particularly in nasal obstruction. And furthermore, sinuses are better accessible to local treatment, and that increase disease control. In my opinion, if a patient has never undergone surgery, endoscopic sinus surgery should be considered. If symptoms are not controlled with adequate medical treatments, such as nasal irrigations, local corticosteroids, and a brief cycle of systemic corticosteroids. On the other hand, if we have a patient who have never undergone at least one surgery, one criticism could be if the surgery was appropriate, if it was complete, and if extension was based on the endotype of the disease. We are discussing about this point because actually there is not agreement about that. In short, if a patient underwent adequate surgery, biologics should be proposed as an alternative treatment. And there is also the situation of patients not fit for surgery. And in this case, biologics may be proposed as first-line treatment if they satisfied the right criteria. Nevertheless, the crucial point is, what do we mean by fit for surgery? Some patients totally refuse even the idea of surgery, and not because there are significant contraindications to be operated on. Finally, we have the situation of patients who perform adequate surgery, but symptoms and polyps recur very quickly post-operatively. And in addition, there are some cases that underwent multiple surgeries, and in these cases, it makes no sense to me to propose further surgery. So we have also to consider comorbidities, and in particular asthma, and its severity. If asthma is the driver of severity, it is more appropriate to start with biologic, and surgery may be considered as a salvage treatment if nasal symptoms are not controlled. And finally, there is the topic of negative predictors of surgical outcomes. There are patients with an high load of inflammation that we name I type 2 patients, and some may speculate that in this patient we should start with biologic, but there are not enough data to support this now. So with this premise, you can understand how is important the counseling. We have to speak very well with the patients and clarify the options available now.
I knew it wouldn't be that simple, and I really like the points that you made there, and particularly talking to the patient. So let's talk to the patient. Alexandra, if I may bring you in now. Tell me, in that introduction, I sort of gave a summary of what it's like to have CRS with NP. Tell us, what are your symptoms and how it sort of presents for you?
Well, I was luckily operated by Dr. Wieske Fokkens. The last time she operated me, it was a draft 3 operation, which means that she made, obviously one of the doctors can better explain the draft 3 operation. However, it was a very severe operation, and the quality of life was for me, although I was still able to work, I had a lot of sickness days. And had to recover from operations every time, because I think I have had like 20 operations in total, which started with the Coldwell look, which was when I was in my teens years. That meant that they open up in your mouth, and they get away all mucus and everything, and they stitch everything in. Well, I can tell you that it's a tremendous impact on your life, especially when you have to deal with day-to-day business in your life.
Well, absolutely. And of course, you mentioned there taking time off work, and also, and you make a really interesting point about growing up with this. And clearly, having those symptoms has a huge impact. We talk about the psychological impact of this. For young people, this must be absolutely horrendous.
It is, because for me it also had included ear operation. So I had loss of hearing, but not due to difficulties with hearing, but because of the mucus now, sort of find its way out through my ear. So I had to wear a hearing aid for 10 years. Till the time Dr. Fokkens suggested biologicals for me. And since then, it's unbelievable, sort of advertisement. But I didn't use the hearing aid anymore.
I mean, that is really quite extraordinary. Well, let's bring in Professor Fokkens, if I may. I mean, it sounds absolutely horrendous. And I think many physicians probably underestimate the impact on people's lives. I mean, it really is very significant, isn't it? As we heard from Alexandra.
Yeah, it's absolutely a terrible disease. And very often, that's one of the things my patients tell me all the time is, I would rather have cancer. You know, they say there's nobody who understands how I feel. I can never sleep through the night. I always feel, well, imagine how you feel after when you have a very severe cold. That is what patients feel every day of their life. They can't sleep, they're blocked, they can't smell. Smell is very important in you can't smell when there is a fire, so people are afraid. They can't taste their food. Very often they also have asthma. So it's a horrendous disease. You hear what Alexander told, being operated so many times, and every time again we try to remove the polyps again and remove as much of the diseased mucosa as possible and give access to local treatment. But in severe patients like she is, that's just not enough. It doesn't help.
Thank you very much indeed. I'd like to bring in Professor Han now, if I may. I mean, I think all of us as clinicians are aware that medicine is a constantly evolving field. It changes all the time. I mean, a number of people have mentioned biologics. Alexandra mentioned biologics there as well, about revolutionising that kind of patient experience. Could you just explain what biologics are? That would be a very good place to start.
Yeah, so biologics are a new class of pharmaceutical treatment for our patients with CRS with nasal polyps. I mean, they've also been introduced in other diseases, as chronic diseases as well, like asthma, atopic dermatitis. We even see in people with rheumatoid arthritis. So these are not small molecules. These are proteins. They're specifically called monoclonal antibodies. And what they do is they target specific inflammatory cytokines. So as Whiskey said, like the IL-4, IL-5, and IL-13, these monoclonal antibodies specifically target these inflammatory cells that are causing those chronic inflammations. So that's what biologics are in kind of quick summary.
Thank you very much indeed. I mean, I think all of you have really encapsulated this brilliantly about the recurrent surgery, the fact we saw the disease burden there from Alexandra, and of course the biologics and how they have changed and revolutionised patient care. Thank you very much indeed for the moment. That was incredibly informative.